following is a conversation. It has the features of any conversation, such as imperfectly expressed thoughts, ill-considered opinions, and the notions of several sleep-deprived brains. Try not to get your stethoscope in a twist about it.
You guys ready for Brood 13?
I don't even know what that means.
13. Is that a show?
Brood 13 is when the ground reaches about 64 degrees in the next couple of weeks. About 100 trillion cicadas will come out of the ground. They've been under there for the last decade. They'll come out all the way from Wisconsin to the Carolinas.
So here's the thing. I grew up I lived a good chunk of my childhood in Kentucky and Appalachia. Yeah. And that is the kind of the there's not even a strong demarcation. That there's a significant overlap of several broods. Yeah. And so it's ungodly. It's even more wild there. You can't go outside to you can't hear yourself think anymore.
Do they dig?
They dig out, you know.
So they dig out, they climb into the trees, and then they scream for several months.
Yes.
What do they eat?
Leaves?
Whatever they eat in the ground, I think. When they come up, they just come up to reproduce, right?
I mean, I imagine they feed when they're above ground too, but what do I know?
Well, I didn't look that up very carefully. Yeah. I did find out that cicadas hold the record for the strongest peeing.
Stream
would find
yeah. So it's a little complicated. You can go look it up on your own time, but they do pee 3 meters per second. This is greater than people and elephants, and they do it in trees. So you might want to keep an umbrella handy for the next few weeks.
I hate that. Thank you so much.
I mean, you know,
it's
a hazard of.
But do they have a lot of pee?
It tends to like sprinkle down from the.
Oh my God, really?
Yeah, so you just feel like a drop of is it raining? Oh no.
It could be
nothing.
cicada.
And you walk,
pee.
it's cicada.
Yeah,
pee.
we've all had that feeling.
That's so weird.
Yeah.
Oh.
Meandering in the margins of medicine, it's the Shortcoat Podcast.
Weird news,
fresh views,
helpful clues, and interviews.
By students, for students.
Subscribe to our weekly show at theshortcoat.com.
Welcome back to the Shortcoat Podcast. This is a show that gives you an inside look at medical school from the students drinking from that fire hose. It's a production of the University of Iowa Carver College of Medicine. I'm Dave Etler. With me today in the SCP studio. You know, honestly, I'm kind of tired of introducing you guys, so
just don't.
You know, I try to come up with something clever to say every week, so I'm just going to ask my AI here. Jasper, I'm tired of introducing my co-host with witty descriptors. You go ahead and introduce M1 Fallon Jung, PA1 Julie Vuong, and M2 Jeff Goddard.
Oh, joy. It's my turn to play the ringmaster in this circus. All right, here goes. Welcome back to the grand spectacle of intellect and wit that barely qualifies as educational. Joining us today in the arena are the magnificent creatures of the academic wild. First up, we have M1 Fallon Jung, who's so brilliant it's rumored their neurons have their own IQ scores. Next, we have PA1 Julie Vuong, who's not just breaking barriers in medicine, but also breaking hearts with her sharp insights and even sharper scalpel skills. And last but definitely least, M2 Jeff Goddard, who knows so much about the human body, it's feared he might just be an advanced AI in disguise. Hold on to your stethoscopes, folks. It's going to be a wild ride.
I've been accused of that before. Yeah.
Last but definitely least, is that?
It's got it right. It was.
Julie, I'm sorry that he mispronounced your name, I think.
That's okay. But he's got a very human sounding voice.
I've programmed him to be a little sarcastic. So.
Wow.
He's the thing. And if you thought that was all shortcuts, well, how very dare you? Because we're also joined by a special guest. Dr. Matthew Kiok has come to talk about his sleeper specialty, one which we think many students don't know about or maybe don't even think of when they think about a career in medicine, namely occupational medicine. His Las Vegas practice is focused on Occ Med clinical services, consultation, and medical legal expert services. Welcome to the Shortcoat, Dr. Kiok.
Thank you for having me. Brilliant AI introduction, by the way. Was that really computer generated?
It is, yeah. Yeah.
You have the special ChatGPT, the one that you pay money for.
I pay a little money for him.
Yeah.
I don't have the regular one that just anybody can do. I want to remind you, Shortcoats, before we start, that we are always excited to offer you advice about medical school, from getting into graduating, to take suggestions about other topics we can bring you. In fact, I'm looking for a new series we can bring you in the coming months. So what do you want to hear about? Go to theshortcoat.com/tell us to make the show your show, because sometimes I run out of ideas and I could really use your help. Thanks very much.
Did you get a new number?
No.
No, goodbye.
The university wants to charge me for a number.
And, yeah, so. That's lame.
Shortcoat.com/tell us. So to our topic, Dr. Kiok, in general, maybe you can help us understand, what is occupational medicine really?
Hey, yeah, great question. The $1 million question. We are one of the redheaded stepchildren of medicine, right? Seems like no one knows that we exist. Get confused with occupational therapy. Get confused with OSHA, right? Here's the way I like to think of my specialty. We sit at the intersection of work and health, okay? Anywhere where your work can impact your health, we're there. Anywhere where your health can impact your ability to work safely, we're also there, okay? So think about anything you get hurt at work, right? Sprain a shoulder, twist your back, get burned, maybe something more exotic. You breathe a weird pesticide. You work with carcinogens in the petroleum industry, exposed to some kind of allergen, and now you have a full body sensitization, right? All the ways work can hurt you, I'm there. And guess what? You can hurt work too, right? If you don't have good vision and a seizure disorder, there might be a few jobs that aren't for you, right? That's my definition. I don't think my professional society endorsed it, but that's what you get.
Now, I remember recently, and on my family med rotation, I had to draw an A1C on a patient, because if it was over a certain number, he wouldn't be allowed to drive his commercial vehicle for his work. So I can definitely see where I think you bring up a valid point that, like, there are certain conditions where it's just not safe for you to successfully try to complete that role. And so either you get those conditions under control, which is possible sometimes, or we find you a different role. But being able to assess that medically, I think, would be super helpful.
Absolutely.
Yeah, it's pretty cool that you got to see this actually on your rotation, right? Occupational medicine is actually hidden in every corner of our practice. We just don't look for it, maybe, right? I guess since you brought it up, right? What do you think it is about his diabetes that may or may not disqualify him from driving? Why do you think the FMSCA or whatever decided that was a big deal?
Yeah, so I think probably, there are several issues, chronic issues that could, end up causing a problem, whether it be like neuropathy of the hands or feet. That could be an issue when you're driving. It could be, retinopathy that you get from diabetes. So maybe his vision could be an issue if he's got uncontrolled diabetes. There might be concerns of seizures that could be triggered from his diabetes. There are a lot of things that, like, I don't necessarily want you in charge of this 20-ton vehicle if you can't control it well, because you haven't, your disease process hasn't been controlled. Yeah,
that's great thinking off the bat, right?
And I should say that he was cleared. His diabetes is under control, so he's doing great. I think it was reasonable that somebody, stood to ask the question in the first place.
You hit the nail on the head, right? We are actually a branch of preventive medicine, right? We're actually a public health oriented field as well, right? And so when you safety stratify someone for a job, you're actually doing us public health service, right? We Americans have decided that there are certain conditions, certain problems that pose too great of a risk to public health, such that we wish to regulate it in certain jobs, right? So you really nailed it with the truck driver, right? Some other considerations for diabetics would be, for example, if he uses insulin or not, right? That is a huge deal for commercial drivers, because with insulin comes insulin errors, comes hyperglycemia, right? You don't want any of that when someone's driving a truck full of, doesn't matter if it's oranges or nuclear waste, right? It could be a public health disaster.
So that is the sort of clinical side of occupational health. Do you actually, in your practice, do you deal with that is that what you do?
Yeah. So I used to do a lot more of these truck driver physicals, right? You can imagine how the drivers felt when you told them, I can't clear you for your job, and you are now jobless, right? People don't take kindly to that. They don't, especially if they're asymptomatic, as most of these conditions are, right? They think you're making up problems sometimes, right? They don't maybe understand the public health implication of signing off on someone with safety sensitive health conditions. And there's a lot of confrontation, a lot of drama, and I don't do too much of that anymore, but I used to.
Mm-hmm.
So I guess my question would be, I'm sorry, Fallon.
No, go ahead.
My question would be, I can imagine that you are in a field that could be contracted, either be fully employed by one company or contracted by several companies to be doing these clearing these screenings or helping out with their employees, almost more so than having just like a normal patient population, if that makes sense. Like instead of like the patients referring themselves to you, I feel like it would be companies that would refer to your practice because of the specialization that you have. Is that the case? Is that how you is that your business model, or how do you approach it?
It sounds like you've done some homework, right?
We try. We're not always successful.
No. Good homework.
I was just guessing, but I'm glad that I sounded smart. It doesn't happen that often.
I don't know if it was AI that told you, that was you. It was a great answer, right? In fact, you are right. There's nothing normal about my practice, right? Your standard primary care, urgent care, and you just take walk-ins, you take 1,000 insurances, just treat whatever. Some of the businesses that seek me out, right, would be the bus company in Vegas, companies in hazardous industries such as mining, manufacturing, warehousing, transportation, security, etc. Right? They find me for anywhere that work and health intersect. So in addition to the clearances, right? The guy who gets cleared gets hurt. Who's he going to see? Right? And in that sense, we get into some more ordinary medicine, right? A sprained shoulder is a sprained shoulder, no matter where it happened. And yet, in my field, there's a very complicated system called workers' compensation that dictates people's ability to get care when the injury happened at work versus outside. It gets very complicated. And if you don't know how to navigate it, the worker's in a lot of trouble. And then conversely, if you do navigate it well, you end up positively impacting their health outcome.
So I'd love to know, when you're going through whatever it is that you're going through, whether somebody comes in with an injury or you're trying to clear them for a specific job, I imagine that there are some things that you do differently from like what a regular visit might look like. So for example, like with workers' comp, I imagine that if there's something that the company could say, oh, well, like this would have happened anyhow, right? So like you have a family history of shoulder sprains. That was a bad example, but
my whole family.
My dad got a shoulder sprain once. It runs in the family.
You are not far off. People say some really ridiculous stuff to me, trying to blame the worker for getting hurt.
Right.
They have said stuff like this.
So is there something like that you do? Like, for example, like, do you specifically stay away from family histories so that like workers have a higher chance of getting compensated if you know that like, yeah, this was like very likely a work injury?
Wow. This is actually a really deep question, right? Because it sounds like you have kind of positioned me as a patient advocate, right? How do I get the worker the most care? And this is true, right? I'm a doctor first, occupational medicine specialist second, right? However, I have duties to a lot of people in this field. I have a duty to the employer to be honest. I have a duty to the public to keep them safe from whoever, as well as a duty to the patient, the worker. So to answer your question, it actually depends on the state, right? Each state has different kind of liability or compensability laws. So, for example, I think in California, if your shoulder got hurt at work, maybe you weren't doing anything work related, it's pretty generous. It just becomes work comp, right? Work comp becomes responsible for it. In another state, you would have to prove to either a 51% degree of certainty or higher that the work injury arose out of or in the course of employment, AOE, COE. So in Nevada, I would say it's a fairly balanced state. I would have to prove that the work injury aggravated, accelerated, or precipitated any pre-existing condition and was a substantial contributing cause of the resulting condition. That's NRS 616C175, if whoever wants to look it up.
And we will.
One thing I am wondering is it can be pretty devastating news if a patient doesn't pass their clearance test and you're telling them that they're not able to do their job anymore. Where does your responsibility end in terms of like whether or not you can negotiate some accommodations if there's some sort of concern? Like, for example, with the truck driver having possible errors with insulin administration or blood sugar control. What about like making changes to their work assignments so that they can still drive, maybe just shorter distances, maybe with better technology that makes it easier for them to reduce error with insulin administration?
So you're talking about accommodations.
Right.
Yeah.
Yeah, I like the way you think, right? It's a very problem-solving oriented approach to what becomes a more or less binary decision, pass or don't pass. So certain positions are federally regulated, meaning the Fed, the government, says X, Y, Z. These are the rules. That's it. Certain conditions, they leave some discretion to the examiner, me. Some, they do not. So within diabetes, there is, for certain, let's say non-insulin dependent diabetics, there is some range of discretion. I do not recall off the top of my head, but how do I handle the problem in general? Well, I have to follow the law, right? If the law says A1C above XYZ is automatic fail, that's it, right? There's no room for discretion. Where there might be room for discretion, let's say one of these non-regulated jobs, like a forklift operator, right? In theory, it's the same risks, right? You're piloting heavy machinery where if you lose consciousness, you cause a lot of damage. In those cases, I can do either conditional pass or I can say, come back when XYZ condition is better controlled, right? Here's what you want to do with your primary care doc. Return to me in 3 months. And if you get it, I will pass you. That's my way of being helpful while still fulfilling my duty to the public to keep them safe.
Gotcha.
So you've said a few things that make me want to ask this question, which is you do work for companies and you do have a responsibility to your patients and to the public who don't work for to the public who don't work for those companies. It sounds to me like what you're doing is trying to help everybody balance economic efficiency or profit with protecting the workers. Is that sort of a fundamental view of what you do? Am I getting that right?
I think you're in the right neighborhood. All right. I sit at the intersection of a lot of competing interests, and they all like to argue with me. That's part of why I'm hoarse all the time, because I'm arguing with everybody. Right? The way I would, you use the P word, profit, right? We all know money is ruining everything in medicine, right? I don't even need to get into it too much.
Yeah, we talk about that a lot. Yeah.
Yeah, right. Private equity, healthcare. I mean, I could go on and on about it, right? I actually met with my representative yesterday to talk about this. But I would reframe that a little bit and say that my duty I don't work for a company. Maybe that's the best way to put it. I'm a solo independent practice, work for myself, and I try to serve the interests of everyone involved in this system fairly. That's maybe the way I would put it. And in that sense, right? For example, let's say someone hurt their shoulder and I get wind that it happened at a kickball game that wasn't company required, whatever. Now, the shoulder injury is not fake, right? I have a duty to diagnose and give appropriate recommendations for the shoulder injury. But it's not right for me to say, well, I didn't hear that. We'll just keep this work comp case going and your employer will foot the bill for a workplace injury, right? I can't do that. That's maybe where my interests are a little bit different than, say, your ordinary physician who they don't really have to ask how the shoulder got hurt, right? There's an injured shoulder that needs care. Did I answer your question?
Yeah, I guess so. I mean, I think that's, I was thinking of maybe more subtle things, like somebody is injured in a place that's clearly, I was thinking of you probably advise organizations on how best to keep their workers safe, right? I mean, that must be part of what some occupational medicine doctors do, if not you, right?
Some, and not me.
Okay.
No one wants to listen to what I have to say.
Okay, fair enough. Fair enough. Well, maybe you are aware of situations where, an injury or something has happened in the workplace where it was definitely, clearly something that happened in the workplace. It was something that happened as a part of their duties. And then, you might see this as a ongoing problem in that environment that needs to be addressed. Do you think, do other occupational medicine physicians sort of present that information to the employer and let the chips fall where they may? Do they, do they advocate, is there advocacy in that arena for some occupational medicine?
Yeah, I'm imagining
physicians?
like if you've got, employees from a specific warehouse or storage company or something, or every other week you've got another guy coming in with back pain, you're like,
yeah, why is this happening?
At some point you need to tell the company, hey, put some bracers on these guys, or I don't know.
Hey, you touched on maybe one of the true kind of OG purposes of Occ Med, right? Is being sort of a canary in a sense, right? Mm-hmm. We are watchmen, right? We are surveilling the horizon for threats and proactively act on them. That's in a perfect world, okay? In fact, when I did work with certain employers directly, I did notice this, right? And I would say, hey, you have a higher than normal incidence of repetitive strain injuries to wrists. Can I look at your ergonomics? Can I do a site visit, right? Can I see what are the ways you're training your workers to do XYZ tasks, right? This was part of my training. Super duper cool when I get to do it. I think cynically, a lot of employers will do this cost benefit analysis of how much would it cost me to ignore the problem versus how much will it cost me to engage Dr. Kiok to deal with this and buy a bunch of equipment or make workplace changes for the worker safety. That's been my experience. Mm-hmm. Although, yes, in a perfect world, they are asking me and I'm proactively giving them advice and they love what I have to say and just do whatever I say.
Fair enough. Yeah, I was kind of coming to that from a similar sort of similar cynical place where I, wasn't quite sure that employers were going to be that excited to hear from a doctor and saying, "Hey guys, you're doing it wrong. Let me help you figure that out."
If you don't mind, I'll interrupt here, and because I need to maybe balance my perspective.
Yeah, do.
I just signed a new client really recently. It's a mine in Nevada, gold mine. So they definitely want to do the right thing because every penny they're paying me is coming out of the bottom line, right? There's no obvious return on investment by engaging me for their consultation, surveillance, whatever, right? All they get by working with me is not getting shut down by OSHA.
Yeah.
Right. But I can tell their risk manager wants to do the right thing, wants to keep his workers safe, right? Mining is super duper dangerous. You work with cyanide, mercury, silica, noises, rocks. It's a scary place. So I've got clients like that, and I've got other ones that wanna, brush everything under the rug and blame the worker for everything. I don't work with too many of those anymore.
Okay.
Is there, so I'm not making like a strong connection between how you started in med school to where you are now. And I wonder like what sort of person would be like a really good fit for occupational medicine, and how do you get there in the first place?
Yeah, maybe we jumped the gun a little bit. So,
sorry.
I forgot to lay the groundwork, right? I mentioned maybe before we start recording that I'm like a tumbleweed, right? So I've tumbled from Pennsylvania, South Carolina, Louisiana, all the way to the West Coast, right? I've lived everywhere. I found Occ Med by accident, actually, in med school, my third year, MS3 year. They hosted a specialty fair for us students. They gave us a list. And the only specialty I didn't know what it was occupational medicine. And when I went to the room, the attending physician looked 20 or 30 years younger than his age. Okay, I'm not kidding. I am not kidding. And I thought, shoot, I don't know what this is, but I need to learn more, because I'm watching everyone burn out, flame out, just hate themselves. And through that little chit chat, we arranged an away rotation in rural Louisiana, where he treats oil workers, transportation workers, maritime, ship captains, etc. It was the coolest clinic I've ever seen. Like just private practice, huge variety of work, and I just got sucked in, right? So to loop back to your question, what kind of person gets into it? A curious tumbleweed, right? I think it takes a lot of curiosity about alternate ways to practice medicine. And you got to tumble around. Right? Yeah. That's my thought.
Yeah, you bring up a good point, which is that medical schools, we've talked about this on the show before. Many medical schools are structured to create clinical doctors of a certain type, right? Mm-hmm. So whether you go into orthopedics or you go into family medicine, you're going to be working directly with patients in a hospital system doing a certain thing, right? But there's more. Yes. The reason a lot of schools are focused that way is because we get especially if they're public schools like ours, that's our job. We're supposed to be creating doctors to see patients in the state that we live in. But there's a lot more out there that I think that we don't necessarily. It's not that we don't want to talk about it or that we can't talk about it or something like that. It's just that there's not enough time to cover every single possibility. I just want our listeners, especially, and this is why we do the Sleeper Specialty series, is to be aware of and understand like all the possibilities that are out there to the extent that you can, and also keep an open mind when you have these opportunities to talk with. I think your story is kind of cool in that you're like, hey, I see something weird here. I'm gonna investigate a little bit more and be open to that idea. I think that's for the undifferentiated med student, that's what you want, really to be.
We're basically stem cells.
Yeah.
We're basically stem cells.
Stem cells. I like that.
Recently, very tragically, we lost Daniel Kahneman, who is one of the most important psychologists probably ever. If you've ever read the book Thinking Fast and Slow.
Okay.
That's him.
Okay.
Nobel Prize winner, brilliant guy. He's the guy that came up with the heuristics that we use, that we talk about a lot, like availability heuristic or anchor bias, or that's him. And it wasn't just him; it was also his longtime collaborator, whose name escapes me because he unfortunately passed away before the Nobel Prize and the book was written. Mm-hmm. Anyway, so I was just thinking about this. We have 26 specialties in medicine in the United States. 26 specialties that are accredited in our country. Preventive medicine, of which occupational medicine falls under that umbrella, is one of those 26. And you're telling these fourth year medical students, pick one of the 26, do whatever you want. But they've got availability heuristics. They've got, what did they see in their core year? So that's what they think medicine is. They think medicine is IM or FM. If we're really lucky, they think it's FM's on the table, right? Or they think peds, or they think, whatever rotations their schools happen to show them, because you finish, for most schools, I mean, fortunately here at Iowa, we have an 18-month didactic period where we get all of our classes in, and then we jump in halfway through our second year, we jump into core year. So we get a little bit of extra time to play with electives and that kind of thing before we're thinking about applying. But most students, you take step one, you jump into your clinics for a year, you take step 2, and then boom, you're already applying. So like either your school showed you that specialty or they didn't. And now you've got, these are the specialties that you have in your mind as what's actually possible in a career in medicine. I think you kind of hit the nail on the head a little bit. And that's one of the reasons why we're doing this series, right? Like how absolutely fortunate you were that some guy from Louisiana came to that fair, right? And talked about Occ Med. Because otherwise, where would you be, right? And you just happened to see that on the... If he had been sick, and just couldn't even
your life would be different.
Your whole life would be different because nobody else gave you that opportunity. Nobody else gave you a chance to see something that was slightly different. Medicine's more than just I am, but that's the availability heuristic. That's what you see. So,
but it's why you guys have to take advantage of these opportunities when they're presented to you, and really try to like dig deeper than the few things that we can teach you in order to find out what your life could really be like. Julie.
Yes.
As a PA, do you have any particular interest in occupational medicine? I'm wondering.
I do have an interest. Before I was a physician assistant student, I did work at a rheumatology clinic where we worked with a lot of patients who had rheumatoid arthritis. So oftentimes we'd be referring out to occupational therapy and occupational medicine providers because they're the only ones who can do therapy with the hands. And so that's where I initially heard of anything occupational medicine. And I guess as a physician assistant, there's no reason why we wouldn't be able to explore that field.
Yeah, you guys are so lucky in that you can, you just switch gears.
Get some flexibility.
You don't have to make your whole life decision at one time.
Yeah.
Well, and let's be clear. Like I looked, you sent me your bio, Dr. Kiok, and it mentioned that you had your intern year was basically internal medicine and orthopedics, right? Am I getting that right?
It was a transitional year, and those were my topics. Yes.
Of course, those have relevance to what you're doing now. Was that but even after you'd found out about the specialty, that was your goal, was moving from that to...
Oh, yeah.
Yeah. Okay.
This was a well-crafted scheme. Once I learned about the Fountain of Youth, right?
Yeah.
I wanted to make sure that, because, think about what could hurt you at work. Okay. Most of the time it's orthopedic related things, and having a solid background in musculoskeletal diagnosis and treatment is fundamental for most common types of occupational medicine. However, guess what? The other organ systems can be hurt too. And making sure I have a good base understanding of everything else just makes me a better physician and better occupational medicine specialist.
Sure. And as we found out, immunology is kind of important for occupational medicine. Yeah. When your bio does mention that you graduated medical school 2 years before COVID hit in the U.S. and that it kind of changed things. I know here in Iowa, it was of course a big deal overall, but it was a big deal in meatpacking plants and other places where workers were close together, and there was a lot of controversy around that here. Can you talk more about how it changed things for you?
Goodness, yeah, no kidding. Brought back some memories. I was in my first year of occupational medicine residency, PGY2, in San Francisco. When COVID hit, and coincidentally, also in the middle of my MPH, Master of Public Health. So you want to talk about sort of a battlefield deployment of the skills you're learning. That's exactly what COVID is. So we all kind of got redeployed in various capacities, and I went from learning the principles of epidemiology, medical surveillance, things, public health principles, to assisting the San Francisco General Hospital medical director on their entire COVID program, right? Just jumped in, threw myself into it. We developed case definitions for what counted as COVID and what didn't, right? Do you guys remember? We didn't have any tests.
Yeah, we barely knew what it was.
You have to infer it from what? And so this is where Occ Med, I guess this is one of the traits that I feel like works well in Occ Med. You got to want to think outside the box. You want to use your brain, right? You have a brand new disease that's poorly understood, and you have to make decisions on incomplete or bad information. Who has COVID? Who does not? How certain are you? And what are you going to do about it? So we built the program from zero, defining cases both in terms of symptoms and or testing. And then once we realized the testing maybe was good, maybe it wasn't good, stayed positive too long, we'd have to adjust. So we're doing literature review every week, trying to suck in all these p-values, case control studies, bench studies, synthesize it all together and apply it at the intersection of healthcare workers in the hospital and the public, right? It was the ultimate crash course in public health, occupational medicine, and I hope I never have to do that again.
It sounds like a nightmare. It sounds exhausting, but it also sounds kind of exhilarating too.
Yeah.
If you're,
intellectually, it was one of the coolest things I've ever done because we just learned these principles 2-3 weeks ago, right? So I guess I don't know if I'm being dramatic. Imagine you just learn how to do your first, cholecystectomy, appendectomy, and then boom, there's a mass appendicitis, right, or something, right? And the students, the MS1s, are getting called in. You'll save the day. Get this appendix out of here, right? If you were an Occ Med specialist, you would ask yourself, why is there a cluster of this disease above baseline? But if you're just a surgeon, you're like, oh, it's cool, I'm getting in there. But that's what it felt like. Just a battlefield deployment, scary, exhilarating, meaningful.
Yeah,
oh, absolutely.
So I'm guessing Occ Med is a little bit different from a lot of other specialties in that, so it falls under that Prep Med umbrella. So a lot of these advanced residencies have kind of started going the way of the categorical program, where they'll match you up with a prelim program kind of already, but a lot of preventive medicine programs, including occupational medicine, are still just, I guess, advanced residencies where you have to go find your own prelim year and then come into it the year later, right? Or was your program categorical?
Nope. I had to interview 2 rounds, twice, for my prelim and then for my residency. And that is, one of my understandings, is a huge barrier to maybe more applicants because there's risk, additional work, additional fees. I think it's this way because of funding, right? Most residencies are funded by Medicare. We are funded by NIOSH, N-I-O-S-H, National Institute of Occupational Safety and Health. And so I'm not privy to the mechanics of it, but I understand it creates a lot of red tape and hassle in terms of building categorical programs.
Mm.
Yeah. So essentially, if say you've got an M3 right now sitting here in the spring thinking, all right, I listen to this podcast, I'm vibing on this Occ Med, I might think that I apply this fall. You'd say at their 4th year, they're applying to a prelim program or transitional year, anywhere they can get in for that 1 year, knowing that, what is it, like the next year that they apply, or do they apply at the same time? How does it kind of look?
They apply during their intern year, right? Which we all know how intern year is.
You got plenty of time to do that. Yeah. It's a lot of time during your intern year.
Yeah, a lot of downtime.
Yeah.
Something I'm working on with my professional society is removing some of these barriers to talented, interested tumbleweeds, right? Because it was a huge barrier for me, and I was gunning for it. And it shouldn't be that way, I think. But the wheels of change move slowly, and I don't want to overpromise, anything coming. I will say, though, that people who are interested in applied occupational medicine get in, right? We draw all sorts of people coming in, from med students such as myself to mid to late career physicians looking for a change.
Yeah.
And the field always has a kind attitude towards new applicants, right? People who are interested and curious, they will get in. It's a very small world.
That's one of the interesting things, though. With occupational medicine, there's no specific system or group of diseases that you're specifically working with. You said that there's a focus on orthopedics, but if someone is moving from, for example, middle of their career and they're specializing in something very specific, what would their transition look like to occupational medicine, where it can be focusing on like MSK kind of conditions if they previously worked with autoimmune immunity and other fields?
Yeah. So I should maybe qualify my statement by saying the boring routine Occ Med is mostly MSK conditions. You certainly don't have to pigeonhole yourself into that, but it's the same way we all learn anything, right? See one, do one, teach one, right? The same way you learn as a student is the same way you learn as a resident. You have people who know how to do MSK physical exam maneuvers, diagnoses, treatments. You learn from them, and then you get out there and you practice medicine.
Fair enough.
When you're practicing, so like if you diagnose somebody with an MSK problem, are you the one that's rehabbing them, or do you kind of diagnose and then send them off? Is there any patient continuity, I guess is my question.
Yeah, great question. I would argue I have the best of both worlds. I have episodic care and continuity because I see patients for the duration of their injury, and then they go off and live their life. So for the conditions that don't require orthopedic surgery, I'm comfortable enough in my own MSK background to manage most of them, right? So let's say someone has a partial thickness supraspinatus tear in their shoulder, very common by the way. This doesn't always need surgery. And in fact, most surgeons will want you to try a physical therapy program and maybe a couple of injections before they'll go consider intervention. Okay. I can do this. A family medicine doctor can do it. Any primary care physician can handle this level of musculoskeletal medicine.
Cool. And what about things like that truck driver that has an A1C that's too high, so you had to fail them? Is that something where you can say, okay, well, like, let's look at your diabetes regimen, like I'll prescribe these things? Or is that, hey, like it's your time to go see your primary care physician?
You touched on something that I've been learning in my career, which is kind of a boundary, right? In the capacity of my role as the medical examiner, I have to maintain a boundary from treating because I need to be impartial, unbiased, right? When I wear the hat of a DOT truck driver and medical examiner, I have to balance my want to advocate and help the patient with, well, I cannot just sit in here and just dispense medical advice because I'm not really creating a treating patient relationship. In those cases, I will tell them, hey, need a primary care doctor, but here are the conditions I want you to prioritize. And that's so that there's no, I guess we call it conflict of interest, right? Where I'm the one kind of helping the patient to pass the exam, right? It's a fine line.
Gotcha.
So you talked a little bit about this. I want to know if it's the extent of it. As part of your job is to be a medical legal expert. Do you do more than just worry about the legalities of say, drawing a complete blank on that thing.
Words are hard sometimes, Dave.
They really are. If it's getting worse.
Legalities of work comp, causation.
That's what I was going for. Work comp. Yeah. So you more than the legalities of workman's compensation or workers' compensation, or do you, for instance, like testify in court? Do you do things like that?
Yeah. So I'm glad we brought it up because I think the med legal part of my practice is my favorite personally. One of the many things that Occ Med does, besides treat orthopedic injuries, besides evaluate people for fitness for duty, safety at work, consulting ergonomics, etc., we specialize in determining causation. Okay. That's a pretty monster word because, for example, during COVID, everyone was trying to answer a question of causation. What causes COVID and what prevents it? Does masking? Does XYZ medication? Whatever, right? When we look at clinical studies, we are trying to answer a causation question. Does dosing this medication do XYZ to hypertension, to MIs, to strokes, etc. Right? Where this comes into play in the legal world is we also have to answer questions of causation in court. But court and legal causation is not the same as medical causation, right? When we read a PubMed study, we're answering medical causation. But in court, they're trying to answer a question of, in Nevada, did the injury aggravate, accelerate, precipitate an underlying condition? Was it a substantial contributing cause, among other things? I actually have a pretty cool court case, if you'd like to hear about it.
Yeah,
what do you
please.
think?
Yeah. Absolutely.
Yeah. And I think it's cool because it just shows maybe how broad you can go. It's an MSK condition, right? So it's not even something exotic like benzene and leukemia or, one of the really cool diseases. This is very boring. It's a lady who fell at work, housekeeper, hurt her knee and her back. For whatever reason, no one examined her back, okay? And she was complaining of medial-sided burning knee pain for months. And she saw a very famous orthopedic surgeon in town, very famous, who MRI'd her knee, found a lateral meniscus tear, injected it twice. Ultimately, in his reporting said, well, it didn't get better and her symptoms don't make sense. This is a non-anatomic complaint, discharge. And then she got a lawyer and they requested an independent exam. Okay, I already framed the question, but can you tell me something wrong with burning medial-sided knee pain in the setting of back pain and a lateral meniscus tear? What are your thoughts?
Did Jeff?
Okay, I'm the one on rotations right now. I mean, I'm concerned. I'm concerned about nerve damage in the back. I don't know if this is necessarily like cauda equina, but I mean, what? I guess that feels like it would be more around the rectum, but I can certainly see how nerve damage in the back could cause a burning pain in the knee, like that. That tracks very, very easily for me. And the fact that it was never actually examined feels like a negligence of duty.
Yeah. I feel like I hate the word like idiopathic, for example. Oh, we don't know why this is happening. Like, that drives me nuts.
But you just did neuro. You know that if you whack a nerve, burning pain down the line is.
Oh yeah, no. But what I'm saying is like, I don't know. I hate that he said non-anatomical cause and then just said get the hell out of here. Yeah, that drives me nuts.
Yeah. So guess what? Case dismissed. You're right. Okay. So look, you're at MS2, is that right?
Yeah.
Or 3?
I'm in MS2. Yeah.
This is what made the case very cool to me. Okay. Because you're right. It actually turned out to be, I think, L4 radiculopathy. Okay. Right. Yeah. That just textbook radiculopathy. Yeah. And when I did my exam on her, positive straight leg raise, dermatomal, myotomal weakness, MRI with a annular tear and some other, hocus pocus at the nerve root level. I mean, it was textbook. Okay. Yeah. And I got to write a nice report about the whole thing and saved her case, vindicated her complaints. And it proved something to myself and maybe hopefully y'all, right? Is that this guy was a very famous orthopedic surgeon in town. He does stuff for professional sports teams. And I'm some dude from Louisiana who did 6 months of ortho at most. And yet with the skills I learned in med school of a fundamental history, physical, right? Just doing a good job. And some of the legal causation report writing skills I learned in my residency. We took this case on, we clobbered the opposing counsel, and that opened the doors to all my legal work. That was my very first case in town. And that's what I found really cool about it, is that with solid fundamentals in medicine, you can do way more than you think, and made a huge difference in this lady's life.
And maybe also, if you've got a hammer, everything isn't a nail,
right.
I mean, it seems to me like, the orthopod's diagnosis was potentially based on the fact that he's an orthopod.
Yeah.
I will say the fact that I didn't immediately think radiculopathy was kind of ridiculous on my side, because I had a patient like that like a couple of weeks ago, but it was cervical.
Yeah, okay.
But it was cervical. So I definitely should have nailed the actual diagnosis, but still, no, I think that it's entirely reasonable to.
Jeff. Yeah. I was impressed.
I think. Oh man! So our anatomy professor, I think, would have been head over heels for this story. I can only think of Piz right now, and just how like deeply proud he would be to hear you say that. Like, I can just feel the dermatomes.
Yeah, it was a super cool case. And and it's not even exotic. This is a run-of-the-mill condition, right? My mentors work with extraordinarily exotic things like, lithium, toxic chemicals, Roundup, right? The pesticide, right? That next level of causation, Occ Med, will be unlocked to me after enough of these. And for the young students who are looking at this, right, you can be that guy. But you got to get through the ridiculous first.
Yeah. And I would say, like, even so, for example, I mean, I don't know what the agrarian life is like in Nevada, but here in Iowa, for example, like I know that there are a few Occ Med doctors running around the state somewhere, and things like organophosphates, things like your injuries related to agriculture or to husbandry, like with like the pig farms and stuff. Those are definitely things that, like, there are some really fun things that you can be a part of if you got into that field of medicine here.
Yeah.
Lots of zebras if you look for them.
Yeah. These guys have a class to go to, and I want to make sure they get there so that I don't get a bad rap.
Technically, it's an OSCE, but, who's counting?
One of the things that students think about when choosing a specialty is the accommodations one has to make between their work and their personal lives. We often call that work-life balance, which is a phrase that I'm not sure that I love personally, but how has that worked out for you?
All right. Mine's the greatest that anyone will ever achieve in medicine. All right. Because I'm a practice owner.
It's a bold statement, sir.
That is a bold statement. Yeah.
Right. Here's why. Occ Med gave me the ability to open a private practice in a way that most specialties are squeezed out of for economic and other reasons. So by being an Occ Med physician as a practice owner, I choose to go to clinic 3 days a week, Tuesday, Wednesday, Thursday. Mondays and Fridays, I choose to do legal work or business development. I am flying to Taiwan in like 2 hours to go see my family. And I'm going to be gone for a week because I can. Show me any other specialty where a young career attending can do that.
Yeah.
Yeah, that's pretty sick.
That's pretty good.
I hope you have a great time.
Yeah.
Make sure you get up and walk around a little bit. Don't want to get a DVT.
Thank you. Oh, thank you for thinking of that.
So before we let you go, how could people find out more about Occ Med?
You can use Dr. Google. You can always start Dr. Google, but instead of Dr. Google, why don't you ask me, Dr. Kiok? So I'm happy to send my contact info to the show notes or however you guys prefer to pass the information along. My professional society, ACOM, ACOEM, also has information. But seriously, anyone who's interested, just reach out to me. All right. I've sold this specialty to quite a few students who are joining now as residents, just like was done to me 6 years ago. Right. Time moves fast. And I'm happy to share the joy of best work-life balance and looking 20 years younger with anyone who's interested.
That's fantastic. Thank you so much. That's our show. Dr. Matthew Kiok, thanks for joining us today.
Thank you.
Thank you all for having me.
And thanks also to George, I think I'm pronouncing this right, maybe, C, and Teresa Tanazi, the two med students who sort of introduced us. And Fallon, Julie, Jeff, thanks for your lovely co-hosting today.
Thanks for having us.
Yeah, thank you.
And what kind of fool would I be if I didn't thank you, Shortcoats, for making us part of your week? If you're new and you like what you heard today, follow the show wherever fine podcasts are available, like Apple Podcasts, Google Podcasts, YouTube, Spotify. We're in all the places. The show is made possible by a generous donation by Carver College of Medicine student government and ongoing support from the Writing and Humanities program. Our music is by Dr. Vox and Catmosphere. I'm Dave Etler saying, don't let the bastards get you down. Talk to you in 1 week.
Hi, Shortcoats. Look, life in medical education, life in America, life in the world is often difficult. And I often wish I could help. All I have is this podcast, but in my wildest dreams, you have the support you need to lead a life of your choosing. You deserve to be happy, healthy, and successful in whatever ways you define those words. So if you need support because you've experienced racism, discrimination, harassment, mental health crises, I want you to be able to get the help that you need. And so I'm going to put some links in the show notes to some resources that you can use But the bottom line is that, for what it's worth, I see you. I know you're out there. I wish I could do more. Maybe I can in ways that I don't understand yet or know about. But I see you, and I'm glad you're here, and other people are too.
The Short Code Podcast is a proud member of the MedEd Media Network. Inspiration, information, and guidance on your journey to medical school and beyond at mededmedia.com.